We are going to talk about acute rheumatic fever. We are going to study about the epidemiology of this disease. We'll study the pathophysiology, the course of symptoms in the patient. We'll study the specific treatment according to the symptoms, and we'll study the prophylaxis which needs to be given. So let's start by defining acute rheumatic fever. It is caused by group A beta hemolytic streptococci. It affects the children of 5 to 14 years age most commonly. It is seen in poor socioeconomic strata. Coming to the pathogenesis, it operates by molecular mimicry. It has type 2 hypersensitivity reaction. Now coming to the clinical features. Clinical features is like patient develops first the episode of sore throat. 3 weeks, 3 to 5 weeks after the episode of sore throat, he starts having different manifestations. Like the early manifestations are arthritis and carditis. In arthritis, the patient will complain of involvement of large joint. It can be migratory polyarthritis, like in the morning the knee is paining, in the afternoon the elbow is paining. In Indian settings, even monoarthritis is also considered crucial for diagnosis. Coming to the second component, which is carditis. Carditis means all three layers of the heart: pericardium, myocardium, endocardium. Pericardium is involved due to the presence of Ashkoff nodules. Ashkoff nodules in the pericardium can also lead to chest pain. Chest pain on ECG you will find ST elevation, and steroids are useful in the treatment of pericarditis. Now coming to the myocarditis component, which can cause congestive heart failure. There we follow the basic regimen of CHF as mentioned in the earlier video. The Lasix, morphine, nitrates, oxygen position therapy, these all things. And coming to the innermost, endocardium. In the endocardium, most commonly the mitral valve is involved, and mitral regurgitation is the most common manifestation. So in MR, we find a pansystolic murmur, also known as flow murmur. Metastolic murmur is seen, and typically in rheumatic heart disease, it is known as Carey-Coombs murmur. It is due to the valvulitis. Due to the valvulitis, in the diastole phase, some amount of blood leaks from the left ventricle to the left atrium, which produces this continuous flow murmur. So this was the cardiac component. Now coming to the next manifestation, which is the Sydenham's chorea. Chorea is defined as the fast distal involuntary movements of the distal body parts due to the damage in the caudate nucleus of the basal ganglia. It is a late manifestation, usually not coincide with the arthritis. Some clinical features in chorea would be like darting tongue. The tongue would look like a frog or a lizard. The patient will be emotionally very liable. OCD can also be found. Now coming to the next manifestation, which is the skin features. In skin, you will find subcutaneous nodules, erythema marginatum, usually not seen in the Indian settings because they have a very dark skin. These subcutaneous nodules are mobile. They are seen in the extensor aspect in the Oliverian process near the occiput. Now coming to the final, which is really important in the diagnostic, which is the modified Jones criteria. So there are major criteria and the minor criteria. To classify something as acute rheumatic fever, we need two major criteria or one major or two minor, or three minor can also be considered. In major, these five criteria which we have already discussed, which is a carditis, arthritis component, Sydenham's chorea, subcutaneous nodules, and margin erythema marginatum. The only difference is here the modification is like it has been divided into two components: high risk population and low risk population. In the low risk population, we even considered if a patient is having monoarthritis or just polyarthritis, only pain component is present, still be considered it as major criteria. Rest all things are similar. And coming to the minor criteria, which is really simple to understand, which is fever, elevated ESR, CRP, PR prolongation, and polyarthralgia. Now coming to the investigation, we can do the ECG, echo to see some ejection fraction, to see the volume flow. We can also, to exclude the diagnosis, we can do anti-CCP double stranded DNA to rule out SLE. And coming to the management includes to manage the arthritis component, we give arthritis aspirin or naproxen. To manage the chorea, we usually give haloperidol, carbamazepine, or valproate. And coming to the last topic, which is the prophylaxis. In prophylaxis, we give benzathine penicillin every 3 to 4 weeks, and it should be always first tested with the test dose. And prophylaxis of the penicillin should always be kept ready, which is undiluted adrenaline, which is given IM 1 is to 1000 in dilution. So this was all about acute rheumatic fever.